Thank you, Dr. Abhijit. I have a short talk on treatment of diabetic macular edema in an Indian setting. And what I'm going to propose is treat and extend is the way forward. So as you probably know, these are the landmark studies in diabetic macular edema, the drcr.net, Right Rise for Lucentis, Vivid Vista for ILEA, and Retain for Lucentis. Now, I would commend you to all go through drcr.net protocols. That's one of the best ophthalmic studies in recent history. And that's what most of us in the world, we follow their protocol. Now, one need not need to go through all the study. All the studies show that on an average, the patients gain about 10 to 15 letters of vision. But in the study protocol, the patients are followed monthly. So some of them in these middle studies, they have a monthly injection, whereas in the drcr.net and Retain, they have a PRN injection. Now that is impractical even in our Western setting. Even in the UK, we don't follow that protocol. We don't give them monthly injection or monthly follow-up. So what do we actually do? So just to highlight that the research protocol is important to show us what is the way forward, what is the way to treat. But then we adapt it to our practice to see what we can actually offer to our patients. So the problem in the real life situation is that monthly visit for the patient is impractical. Now, in our group of patients, some patients will not respond. So there's no point in giving them monthly injection if they're not responding. And some patients will respond with 3 or 4 injections, and there's dry macula. Again, there's no point in continuing to give them a monthly injection. So, but in the trial protocol, the protocol is decided before the patients are enrolled in the trial, and they will carry on for 12 months or 24 months, whatever the protocol is. So that again is impractical in the real life situation. So I'm based in Lincolnshire, and I'm the retinal lead there. So this is the protocol that we have developed, and that's what I'll go through. And the same protocol can be followed by all of you. It's quite straightforward and very effective. So the patient comes to my clinic, and they have a diabetic macular edema. The first thing to ask and to find out whether the fovea is involved or not. So if the fovea is not involved, then you do a grid laser and then keep on following them. And you repeat the laser at every 3 months. So generally, if you have done the grid laser properly, it need not need to be done less than 3 months apart. If the fovea is involved, then the first line of treatment there is to give 4 monthly injections. We have in the NHS, there is no cost to the patient, so I choose between Lucentis and ILEA. If the patient's vision is better than 618, then I give them Lucentis. If it's better than worse than 618, then I give them ILEA. And after 4 injections, we see how they're doing. If they are dry, then I just watch them. So after 4 injections, I would again classify them into 3 groups. So if they are dry, so that I would say that they are success, and then we watch without injection. If they're partial responders, so that they are better, but they're not completely dry, then I keep on giving them injections until they are dry. And the non-responder where there is no improvement at all after 4 injections, so there we look for other causes, and we think of switching. So let's take up the group one by one. So the first group, where after 4 injections the fovea is dry, then I don't inject them anymore, and put them into monitor and extend. So there is we're extending the follow-up. Extend here is extending the follow-up without injecting. So that's monitor and extend. So let's say I will book them to see my 4 weeks. Then if they're still dry, then 8 weeks, 12 weeks, 16 weeks, and so forth. So if the patient is dry at 16 weeks, that means the last injection was something like a year and a half ago. So these patients have done very well. But there's only a small group of patients in this group. what happens is that these patients who are initially dry, at some stage they will start to leak again. And at that point, I will put them into treat and extend. So I'll go through the treat and extend protocol here with you. So let's say these patients, after 4 injections, were dry, and after, let's say, another 4 months, they start to leak. So they enter into treat and extend regime. And this is the regime. You give them monthly injection until they're dry again. And then you increase the interval by 4 weeks or by a month. So let's say after 3 injections, the fovea is dry. The next injection will be at 2 months. And even if the fovea is dry, you give them the next injection, and then follow them after 3 months. And if they're dry, then you give them another injection at 3 months. And so on, you increase the interval to 4 months. And after 4 months, you keep at 4 months for 3 cycles. And if they are still dry, then you enter them into monitor and extend. So the idea is that these patients should not have macular edema. So we give them injection before the macular edema recurs, because commonsensical approach says that whenever the macular edema recurs, there is some changes to the retina. We may not be able to record it either functionally or anatomically, but the macular edema always leads to some changes. So this treat and extend approach reduces the number of visits as well as reduces the damage to the retina. Now, the second group, where the patients are partial responder, so they have responded, but they are not completely dry. So you keep on injecting them every month until they are dry. So they will take two paths. Either they become dry. In that case, we will watch them and wait for recurrence. And if they recur, then we put them into treat and extend. Or the majority of the patient is that they improved partially, and they will stay there. So they will neither regress nor improve, even with monthly injection. So they will be the persistent edema. So this group with partial respondent who have persistent edema even on monthly injection, then you look for the causes. So in my practice, I don't do a fluorescein angiogram when the patients first come to me. I will do this regime, laser or injection. And only when they're not responding, then I will do a fluorescein at that stage. So the 2 main causes for non-responder or partial responder is ischemia. So you can have foveal ischemia or peripheral ischemia. So if you find foveal ischemia, then you do laser at this stage. Remember, these patients had foveal edema. We started with the injection. We haven't given the laser yet. So I will give the laser at this stage. And if you find peripheral ischemia, then we do a PRP laser in the periphery. And of course, you look for vitreomacular traction. And if you find the vitreomacular traction, then however many injections we give, they will not respond. So they need a vitrectomy surgery. Now, you have looked for ischemia, you looked for traction, and given the grid laser, even then they haven't responded, then you switch. So by switching, most of the patients, we have already given anti-VEGF. So normally I would switch to the steroid. So we have access to Ozurdex, which is dexamethasone, similar to triamcinolone. So I think in Indian setting, you can try triamcinolone in these patients. Now, in the group which initially, there were 3 groups. So the third group is where they haven't responded at all. Now, again, you look for the secondary causes. And if you don't find any cause, then this group is very difficult to treat. You can try a switch, or you can try combination therapy, you can try vitrectomy or metabolic control, but they are the difficult ones to control. So in summary, I would say that I treat all sorts of medical retina patients, but diabetic patients are the most satisfying to treat. They respond very well. The problem here is the patient motivation. They are young patients, and they don't see any problem with their eyes mostly, and they don't understand why I want to bombard them with laser, bombard with them with injection when they can see properly. So patient motivation is the bottleneck here. I won't go through into that, but that's the flow chart that we follow. You can write to me. I can send it to you by email. And thank you very much for having me.